Hello and welcome to the Oncology Journal Club podcast, where oncology papers meet real-world practice. I'm your producer, Rachel Babin, and joining me again are Professor Craig Underhill, Dr. Kate Clark, and Professor Christopher Jackson. Together, they dive into the research shaping cancer care, the important, the intriguing, and the sometimes controversial. This podcast is proudly produced by the Oncology Network. Head over to oncologynetwork.com.au for the show notes with links to all of the papers discussed today. Okay, over to you, Craig.
G'day. Welcome everybody to Series 4, Episode 2 of the Oncology Journal Club, or OJC. It's a great pleasure to have Dr. Kate Clark here in the land of a long white cloud. How are you, Kate?
Wonderful. And there's no clouds today. Absolutely stunning morning in Te Whanganui-a-Tara, Wellington, Aotearoa, New Zealand.
Wonderful. Take a photo out the window. Professor Christopher Jackson, how are you?
Yeah, I'm pretty good. So I've just been at the Common Sense Oncology annual meeting, which is in Montreal. And people who've been talking about Common Sense Oncology previously, but this is a group that's been around for 3 or 4 years now, and it's really about trying to refocus oncology on patient outcomes that matter. Things like improving quality of life and ensuring good trial design, good trial interpretation, and good trial communications. It's a really good group, and that's in Montreal. Also got to hang out in Kingston last week with Chris Booth, who was the author of the challenge paper, and do grand rounds at Kingston Hospital and Queen's University. So it's been a just under a week here now. It's been great.
Wow, is Kingston in Quebec as well?
So Kingston's in Ontario. I quite like Montreal. I don't know if we've got any Montreal listeners. If they do, send us a message in the comments, guys.
Yeah. So listeners, we've been very dedicated crew bringing you this episode because we have Rachel, our producer, sitting in Spain near Alicante. We've got Kate in Wellington. Or what was the Maori name for that, Kate?
Te Whanganui-a-Tara, the large water of Tara.
Be careful how you say that. And I'm in Bonagilla, outside of Wurundjeri, and Chris is in Montreal. So we're all 4 different time zones. I'm in my Qantas pajamas because it's 5 a.m. We've got a great episode coming up, so let's get straight into it. Chris, I think you might do your long paper first.
Yeah. So paper just out in the New England Journal of Medicine is a paper called the NeoGOLP trial, GOLP. This is a phase 2/3 open label multi-center RCT from 11 hospitals in China and resectable high-risk intrahepatic cholangiocarcinoma. Now, people with GI cancers are increasingly used to perioperative chemotherapy, of course, or preoperative chemotherapy in borderline resectable and also upfront resectable. It's already the standard of care in gastric cancer, of course. And this is trying to extend it to cholangiocarcinoma, which, of course, has got very high rates of 1 and 2 year recurrence. The study used neoadjuvant gemcitabine with oxaliplatin, lenvatinib, and toripalimab, which is a PD-1 inhibitor, for 3 cycles, so day 1, day 8, between 1 days for 3 cycles followed by surgery or upfront surgery, with both groups then getting adjuvant capecitabine, which I think is defensible in that condition. The primary endpoint was event-free survival, and secondary endpoints included overall survival and safety. So the headline of the trial is that the trial is positive for event-free survival. So event-free survival was defined as people not getting to surgery because of progression or recurrence. And the median EFS was 18 months with neoadjuvant therapy versus 8.7 months with surgery alone. And at 24 months, that's 37% versus 25%. Now, OS is promising but immature. 24-month overall survival was 79%. Favouring the neoadjuvant group compared to 61%. Just bearing in mind the very first study in gastric cancer added 13% and FLOT is adding about 20-25%, so it's in that same ballpark of benefit for that group. But that didn't cross the pre-specified significance boundary, so whilst the P was less than 0.05, they specified the P as much smaller than that because they did some hierarchical testing. So at this stage, it's not an OS positive trial, but there's a real biological signal here. Response rate was 55% and pathological response was 19% and pathological CR 5%. So it's not just noise, the regime's clearly doing something. And there's a couple of things I took away from this trial. For starters, I think the authors deserve credit here. It's a hard disease in which to run trials. It's relatively uncommon. The eligible population's narrow and perioperative biliary trials are quite difficult to complete. They're focused on a high-risk population, which is exactly where you want to have these intensification strategies. Also, the surgical safety data are quite reassuring. Given the inclusion of a VEGF TKI, surgery was performed in 97% of patients in the neoadjuvant arm and 99% of patients in the control. And the complication rates that were reported weren't higher with neoadjuvant therapy. So pretty important when you're packing in a drug that might cause dehiscence or leaks. And so that is good to have that safety signal. But there are some limitations. Just coming back off the Common Sense Oncology meeting, of course, this is the endpoint for starters. Let's talk about the endpoint, event-free survival. This is a curative intent population. So event-free survival is a surrogate. We haven't necessarily validated event-free survival as a surrogate for overall survival. So whilst OS is promising, I think we have to wait for more data. And I think the standard we need to hold perioperative studies to is overall survival. There are issues, of course, with effectively lead time bias based if you're adding neoadjuvant therapy to one arm and not to the other. So you could just be delaying recurrence. It's important to be certain that OS matures. The other thing is I didn't actually have access to the detailed post-protocol therapy. So you had PD-1 therapy in the perioperative arm, but I wasn't clear if you had it in the situation of metastatic recurrence, although the level population for that would be relatively low. It is buried in the supplementary appendices, but I couldn't get access to those, unfortunately, due to the restrictions of my access to the journal. The other thing is there's toxicity. It's not a trivial regime. Quad therapy for biliary cancers in the perioperative setting has to be taken seriously. Adverse events were 97%. That's of all adverse events. That means you're recording toxicities at least. Grade 3 or higher and around a quarter, which is probably acceptable if it's going to improve your cure rate, but we do have to understand the trade-offs there. So the final thing is we don't really see the quality of life data here either at the moment, which is essential in metastatic disease studies, and we have to think about longer-term toxicities with PD-1 agents as well. So on the whole, I think it's a very strong signal-generating study. The regime clearly improves tumour control and delays recurrence, and it appears surgically feasible, which is not a given in the setting. But I think I'd stop short of saying it's a new standard today until we've got overall survival, which is published. But if overall survival does mature, and we get information about the long-term toxicities and some quality of life data, then we'll be in that position to start saying this is something that we should be looking at. So well-conducted, important EFS positive trial with promising but immature survival data, and this will be one for sure. I'm going to be watching closely for that data to mature.
Yeah, interesting. I have a biased population in my clinic, but I'm seeing younger and younger and younger people with biliary cancers. The signal is not as strong as rectal cancer because it's not as common. We've new surgeon who's come from the States, he's blown away by our rates of biliary cancer compared with what he's used to in the east of the USA. So I'm always holding out hope for this truly awful disease that we will get more things that are useful and useful in a curative setting. It's really, really exciting. Did they say what dose of lenvatinib? I just couldn't find that when I'm flicking through the redacted bits I'm allowed to see.
Yeah, now you've got me case. Now you've got me.
Yeah, interesting, CJ, that you selected this. We are seeing more biliary cancers, and as Kate said, there does seem to be a trend towards some younger presentations. I think immunotherapy will have an impact in some subpopulations down the track, but we're waiting on some data on various trials in that. Interesting paper. I have got one to tell you about. This is right across tumor types. This is from a paper from JAMA Oncology. First order Franklin. There's been quite a bit of publicity about this study that's come out of the MOST group, the Australian Molecular Screening and Therapeutic Program. So this was looking at the clinical utility of matching therapies to genomic biomarkers based on varying levels of evidence. They took patients that were accrued to the MOST program. So these are patients with advanced or refractory solid tumours and adequate ECOG score. These patients in this program were recruited from June 2016 to December 2021, follow-up to July 2022. The study's just been published. So they looked at using a framework called the TOPOGRAPH, Therapy-Oriented Precision Oncology Guidelines for Recommending Anti-Cancer Pharmaceuticals knowledge base, which the authors had previously published on. And it gives 4 tiers, tiers 1 to 3A, have prospective trial evidence, tiers 3B and 4 are investigational or repurposed drugs. So tumours are analysed with the next generation sequencing. There's a molecular tumour board. The tumours are assigned one of those 4 levels according to the results of the NGS. Then if there is a match therapy recommended and available, could be on a clinical trial, could be drug that's available, then patients proceed to treatment accordingly. And in this cohort of 3,383 patients from around Australia, and there was a number of regional sites participating, which was great, so enabled access to these treatments, remembering that it's a tumour that's shipped to be analysed in the laboratory for the NGS rather than the patients having to travel. So many regional patients elected to participate. Of the 3,383, 37% had a clinically active biomarker or T1 to 3A. Among the patients with the T1 to 3A biomarker receiving treatment, they had a longer median overall survival than those with an unmatched therapy, and that was 21 months versus 12 months with a hazard ratio of 0.6. So almost a doubling of survival if a patient's tumour had a biomarker that could be matched to a treatment. Patients receiving therapy matched to investigational evidence on Ts 3, 4B, there was an associated survival benefit. It was 14.5 months versus 12.8 months with a hazard ratio 1.04. So in this cohort study of patients with advanced solid tumours with matching therapies to genomic biomarkers had a substantially improved survival when there was supportive evidence from prospective clinical trials. So there's a number of editorial issues that immediately sprung to mind, and that's the importance of enabling access to this testing for patients with advanced tumours. And the MOST program has been exceptionally good. And its subsequent spin-off program called Prospect, they've been exceptionally good at providing widespread access to this testing around Australia. And if patients have appropriate biomarker, they can receive treatment or go on to a match to a clinical trial. It shows this study reiterates the importance of making this testing available and the clinical trials available to as many people as possible using decentralised methodology. So there's been quite a bit of publicity about it. You can read a bit more about it on Oncology News Australia as well. Some of the mainstream media covered this paper as well. So kudos to Franklin, David Thomas and his team at the MOST program for doing this study and publishing it.
The editorial that I read, I think, was quite clear that you can't use precision oncology as a fishing expedition. You have to use it with a sober look at the evidence that when you're interpreting things. And so if the evidence exists that in people with cancers with this mutation, then that is useful. But just throwing a drug on a fishing expedition doesn't seem to help, even though it feels like it should. So I think that was quite useful. So it's matching sensible evidence from precision oncology with sensible evidence in the existing literature provides sensible outcomes rather than let's just give everybody a go at something.
You mean so the very approach that this program
was taking?
Right.
Yeah.
I missed the editorial, Kate.
So there's one in MedPage, and I think Vivek Subia comments on the study in JAMA Oncology as well, and is complimentary about the fact that they were sober about their approach to the molecular targets.
Fantastic. Well,
It's quite good when you've got sober Aussie investigators, isn't it?
Had to get up very early in the morning for that.
Well, I was worried when we set up this program, Chris, that you're at a conference in Montreal and that you'd be sober during the recording, but it's only 4 p.m.
What I really like about this one, Craig, for starters, it's quite a big patient population, which is great. Oftentimes these studies are a lot smaller than 3,000 patients, so it's good to see that large number. I also really like how they've tiered the evidence as well. 1, 2, and 3A, for example, they're matching it to the quality of the evidence, which is good. And clearly labeling 3B and 4 as investigational, I think, is also quite helpful too. I mean, these targets aren't all the same. BRAF inhibitors in melanoma are spectacular. BRAF monotherapy in colorectal cancer is terrible. So, the primary tissue of origin still does seem to matter, I think. So I don't think you can just say it's targeted therapy at the target. Doesn't always necessarily mean it will work. And the driver mutations different in different cancers, the way in which they work. Is it activation, constitutional activation? Is it overexpression? Is it, what is it? The actual driver there. And also, I think we have to be careful about saying that the intervention improved overall survival. I think we can say that the intervention was associated with overall survival because we don't want to conflate correlation and causation because, of course, as we know, 100% of people who conflate correlation and causation die.
Sure. Thanks, Chris. So we'll put a link to the topograph database, so therapy-orientated precision oncology guidelines for recommending anti-cancer pharmaceuticals. So it's a curated database that you can put in the tumour mutation and actually alerts you to some evidence in this field. So that's a joint venture between the OMICO program, Garvan, University of New South Wales, University of Sydney, and the NHMRC Clinical Trial Centre. So that's a useful resource as well.
Before we get back to the papers, if there's a study you think we should be covering on the Oncology Journal Club podcast, feel free to send it our way. You can join the Oncology Network. Remember, registration is free. And leave us a voice note on the OJC page. That's at oncologynetwork.com.au. Or come and chat with us on our socials. And physicians, please don't forget that you can claim CME points for listening to the show. All right, back to the Journal Club.
Cool.
Chris, do you have some quick bites for us?
We've been chatting on our melanoma chat group over the last week or two about the less common subtypes of melanoma, the mucosals and the odd uveal that you get along the way. And that's led us all just to start chatting about the different ways in which we approach these diseases and the limitations of the current evidence bases. That meant that when this study was published in the Lancet Oncology, it, if you'll excuse the pun, caught my eye because this is a study on uveal melanoma. So I'm obviously in fine form today with the dad jokes, guys. This is the CHOPIN study, which is a randomized phase 2 study in metastatic uveal melanoma, looking at whether combining percutaneous hepatic perfusion using melphalan, essentially high-dose liver-directed chemotherapy, with or without ipilimumab, could improve outcomes. So this is a randomized phase 2. Everyone gets continuous hepatic perfusion with melphalan, and then the intervention is with or without ipi-nivo. The ipi-nivo dose is ipi-1, nivo 3, every 3 weeks times 4 cycles with no maintenance. So uveal is obviously a disease which is very different to cutaneous. It has a low tumour mutational burden. It's relatively immunologically cold, and historically checkpoint inhibitors have been much less effective, so they're trying to hot up the tumour using liver-directed therapy and then layer it with immune therapy. And uveal melanoma has a distinct predilection for the liver as the solitary site of disease. So what did they find? Well, this is a trial with a positive signal. The combination of hepatic perfusion with ipi and nivo improved response rates, PFS, and importantly, OS was improved compared with perfusion alone. So unlike a lot of uveal melanoma studies, there's actually an OS signal here, which is what makes it interesting. And this does mechanistically fit the hypothesis of liver-directed therapy leading to antigen release, which could improve T-cell activation, which might actually help the checkpoint inhibitors to work better. Unsurprisingly, there was a higher rate of adverse events, but the authors say toxicity was manageable with no new signals. But the key thing here for the study is the context. And this is where it gets important. So historically, ipi-nivo has got response rates in the order of 10 to 20% for uveal melanoma, which is quite low. And median OS is about 12 to 18 months, depending on the series. So this increases the response rates by more than you see with ipi-nivo on its own. So it's not just testing as ipi-nivo active in this disease. It does seem to somehow be synergistic rather than just additive, even though you don't have the ipi-nivo alone arm, which will be the synergy test. If it was done that. And then, of course, this group didn't have tebentafusp. So for those who treat melanoma, you will know that, I struggle to say this word, tebentafusp is the benchmark. But that requires HLA 2 /01 positivity, which about half the patients, but the other half don't have that. So it's not everyone. So at least half the patients would not have been eligible to receive tebentafusp, which would have left them with IO or liver-directed therapies as the only deliberate ones you can do. So it does show that you can take a disease that doesn't respond well to IO and make it more responsive by combining it with liver-directed therapy, but it's a small phase 2, single centre. Comparator is hepatic perfusion alone, not tebentafusp, so it could only be extrapolated so far to the non-HLA 201 positive patients. And it's uncertain how generalisable this is, and it's certainly a complex and resource-intensive procedure. We certainly don't do hepatic perfusion with melphalan in our centre for this particular indication. But I think it's a good interesting signal and good to see them doing randomized trials. People often say you can't do randomized trials in rare disease subtypes. These guys are clearly proving that wrong. So again, good on the authors for doing that. And that's why I picked this trial.
It's been tried in other immune cold-ish tumours. Like if you can prod this particular bear, why aren't we prodding other bears?
I've not seen melphalan infused livers before, to be honest with you, Kate. So that was a new one to me. But I guess people are trying to do that a bit. I mean, you've got BOT-BEL, colorectal cancer. You have the Rego-Nevo study as well, which is trying to switch off to Tregs. And I guess it's part of the theory, at least, why giving oxaliplatin with immune therapy does increase antigen exposure. So something along the lines of that. And of course, we have this very magical and mysterious property, which everyone has seen lots of cases of, but no one's ever actually written up a case series called the abscopal effect, where radiotherapy is used in combination with IO to actually improve the immune response rates as well, which is something we talk about a lot in our meetings.
So what I'm saying is, if this one works in this disease type, shouldn't we use this mechanism in other disease types? Rather than...
Yeah, I think one of the specific things about why you mean use melphalan is the agent, or liver-directed therapies more, Kate?
Liver-directed therapies, because my proposal is that we all know that the liver itself is part of the problem here because it is immune cold. And so when cancer has found a home in liver, it's protected from immunotherapy, is the theory. The reason why atezo-bev works in liver cancer is mostly you are, at least in part, reversing that. But now we've got a something that works, at least in uveal, or appears to work in uveal melanoma. That's very hard to say. Why not try that in other liver-predominant cancers that are otherwise immune resistant? Use this technique again and see if it's helpful.
Yeah, it's a good point, isn't it? I mean, I was wondering about whether or not it was the infusion of the chemotherapy into the liver, which was also having an effect on local T cells, and that might modify the response. There was some data that Shani presented at ASCO. I'm not sure if you can remember that with me. Help me through this data. But if I recall correctly, it was people who had melanoma and had a melanoma liver metastasis resected still had lower rates to IO than in people who had non-liver-based metastatic sites. And so they're thinking there being something very specific about once the tumour's gone to the liver, there's an immunologic interaction which happens, and someone with a much better understanding of immunotherapy and immunology than me could probably help us out with that mechanism. But that was the data I recall that she presented. Do you have a similar recollection, or am I imagining that?
I don't recall that, but that feels like a negative abscopal effect, doesn't it? It feels like the cancer's almost training the immune system by using the liver as a training ground to say, hey, chill out, you can't see me. Fascinating. I think we are increasingly finding out that we don't know what we don't know, what we don't know.
So sometimes these new innovations raise as many questions as answers. Chris, do you have any other quick bites for us today?
Yeah, I've got one more. It was a rectal cancer study, which is called the NeoGOLP study. So this is a NeoGOLP study, a randomized phase 2 study published in JCO in locally advanced rectal cancer, specifically, again, microsatellite stable pMMR disease. This is the type of rectal cancer that we see the most of. And this is important. So immunotherapy has historically had very limited activity in this group, and it's the growing area. And again, as Kate, you say oftentimes, this is the left side, in particular the rectal side, which is growing in our Indigenous population, particular rectal location. All patients received standard long-course chemoradiotherapy, and then were randomized to receive either atezolizumab alone or atezolizumab plus tiragolumab, which is a TIGIT inhibitor, and TIGIT is another immune checkpoint thingy, which has been tested a bit in melanoma. So far, so negative, but TIGIT's another immune checkpoint that people have been interested in looking at. Question here is, can we improve response rates in microsatellite stable rectal cancer by adding dual immune therapy after chemoradiotherapy? And the primary endpoint was pathologic complete response, which is obviously looking at the signal rather than actually trying to define a standard of care. And the combination arm had a PathCR rate of 36% compared to 22% with atezolizumab alone, which on the face of it looks encouraging, particularly when you compare it to historical PCR rates of around 15 to 25% with chemo-rads alone. And there are also signals of improved downstaging and early separation of EFS curves, although obviously data is still immature. But there are some pretty important limitations, and the first is endpoint. Let's just dive straight into that. A PCR-driven study. While PCR is attractive, it is not validated. It is not validated for overall survival in the setting, and we don't have a true control arm. Both groups received immunotherapy, so we don't know actually how much is coming from atezo or how this compares to chemo-rads alone. And the third, it's a small phase 2 study with immature survival data and no quality of life outcomes reported so far. The other key thing, of course, is where does it fit in the context of modern rectal cancer trials? Now, we've talked about rectal cancer trials a bit on the podcast in the last year or two because there's been a lot happening in rectal cancer studies. We had the OPRA study, which was total neoadjuvant therapy with long-course chemoradiation followed by fluoropyrimidine oxaliplatin, which shows meaningful organ preservation. Prestige 23, which was around FOLFIRINOX, followed by chemoradiotherapy, followed by surgery, followed by a bit more chemotherapy, improving disease-free and metastasis-free survival. And you've got the Prospect study, which went the other way, which was shown in selected patients we can omit radiotherapy without compromising the outcomes there at all. So the field's moving in multiple different directions: intensification, de-escalation, and organ preservation. And so where Neoteric sits, it's a little bit awkward as to where it's sitting at the moment. It says we might be able to improve complete response rates further. We might be able to push organ preservation rates out even further, but it's not combined with the current standard of care, which is chemotherapy and the TNT population. But we might be able to explore it in earlier stages like T2E0, for example. We don't have the answers for what to do for those T2 patients you'd like to organ preserve. So this is a signal finding study. It shows biological activity, and that is important. But it doesn't yet tell us whether patients live longer, live better, or avoid surgery more often. And it's not well positioned currently in the current landscape, so it's going to need to be combined with one of the other strategies that's currently in play, or find a different niche, so a slightly earlier part there. So I think that's going to excite trialists, this one, and drug developers rather than clinicians in the clinic, at least for now. But it's cool to see microsatellite stable pMMR rectal cancer having some immunotherapy thrown at it.
Also, just a very naughty comment, but tiragolumab has done very well in phase 1-2 and not done very well in phase 3 across the board. I do not know why. I'm not clever enough to figure that out, but there's been an awful lot of early signals that have gone away in phase 3: esophageal cancer, lung cancer, liver cancer. So, I'd be curious to see what happened in a bigger, well-controlled, well-consented trial. What would happen? I think I'd be curious actually to know what the team think. If you were offered a trial with neoadjuvant tiragolumab, knowing the biases that I'm coming with from all of those negative phase 3s, what trial would you design and how would you consent your patients to? It doesn't seem to be a signal of danger, but many signals of no effect.
It's a good question, but it sounds like this is a very complicated field now. So how are we going to sort it out, Chris? Is it through randomized clinical trials, comparing these different approaches?
Look, I think it needs to go down RCT with chemotherapy now. So that's what will happen now, won't it? It will be chemotherapy with that dual combination, which I think you can justify. Doing another phase 2, looking at the combination with chemotherapy to look for safety signals and then do a randomization between the two. Okay, when we went back to the old days, and when you and me were both training, we had all those phase 2 to phase 3 studies, which showed that when you went from phase 2 to phase 3, your response rates dropped off by about 10%, and your OS dropped a bit as well. And most of that is disease burden. As people in phase 2s have got lower disease burden than those in phase 3s. The phase 2 study patients are usually younger as well. They're usually less comorbidities, less competing morbidity there as well to dilute signal. But that's why we do phase 3s, is for the maximum generalizability. And so the phase 2s are always signal finders. And I do get worried these days that we are just changing practice more and more off phase 2s, which are hyperselective patients, which don't take those factors of generalizability into account. And so it's always important, I think, for us to still do the phase 3 with good numbers. The point of bringing this one forward is that you've had a tumour which is immune cold up until now. There isn't that much in the way of signal of IO and GI cancer outside of pMMR, and it's cool to see that there's another way other than just VEGF, but maybe targeting the immune cold tumours, another pathway there. So I thought that was interesting, and I think having read that study, if I was offered a TIGIT PD-1 study, given that we've got nothing in that space at the moment, I'd certainly give it a second look for sure.
We all do teach juniors, and I find teaching rectal cancer today is like teaching stage 3 lung cancer 10 years ago. So you can pretty much justify any strategy you want depending on your desired outcome and the patient's desired choices. So it is increasingly complex to understand, to teach the quote-unquote correct way to manage a locally advanced rectal cancer.
Kate, that sounded like a segue into my quick bite. So I've got 3 ASCO guidelines to mention. People can click on the links and read in a bit more detail. I encourage any trainees listening to have a look at these guidelines. I think they're a pretty good way of seeing a evidence-based summary of why we currently do what we do in these various cancers. So there's one out, therapy for stage 4 non-small cell lung cancer without driver alterations. This is ASCO Living Guidelines. This is version 3.0 for 2026, so that's been updated. There is a new ASCO update as well for advanced gastro-oesophageal cancer with immunotherapy and targeted therapy being added. Also, interestingly, who'd have thought that the 2026 ASCO guideline update on managing thyroid cancer? So again, 10 years ago, medical oncologists probably weren't much involved in treating thyroid cancer. Increasingly, they are, as we recognize the different subtypes. There's the common, well-differentiated thyroid cancer, which is treated with radioiodine, but then can become refractory, medullary thyroid cancer and anaplastic thyroid cancer. And there's quite a number of active treatments, again, often directed by the biomarker subtypes of those tumours. Again, I found it interesting to have a look through this guideline. Any trainees listening, I would encourage you to have a look at that because it gives you a state of the art of where we're up to in treating the various subtypes. And we do like a good guideline on the OJC. Then the last one I want to mention is the Chrono-Oncology study. Again, this received quite a lot of publicity in the medical media, including there's a good article on Oncology News, but also in the mainstream media. This is a Nature Medicine paper in lung cancer. Tony Mock in Hong Kong was the corresponding author. This was a randomized phase 3 study assessing the time of day of delivering immunotherapy. So patients were randomized to receive chemoimmunotherapy either in the morning or the afternoon. And with a median follow-up of 28.7 months, the progression-free survival was 11 months in the early time of day group and 5.7 months in the late time of day group with a hazard ratio of 0.4, so a halving in the risk of progression. Median overall survival 28 versus 16 months. Again, hazard ratio of 0.42, a reduction in the risk of early death. And interestingly, they did some translational studies looking at some biomarkers. And over the first 4 cycles, the morning circulating CD8 T cells increased in the early time of day group, and they declined in the late time of day group. And there was a higher ratio of activated CD38 HLA-DR positive versus exhausted TIM3 plus PD1 plus CD8 T cells in the early time of day group. So there was some biological explanation potentially for why giving the immunotherapy in the morning is better in the afternoon. So interestingly, I know that some people are now designing some prospective studies in other tumours. The AGITG group in Australia is looking at a study called Circadian, which is early versus late delivery of immunotherapy in people with gastrointestinal tumours. Oh, sorry, is it gastrointestinal tumours, Chris, or just colon? I can't remember. But anyway, there's more prospective studies potentially to come. But interestingly, in looking at the feasibility of those studies, turns out that a lot of centres have already switched. And so on the basis of this one randomised study in lung cancer, there are units around in Australia who are now switching to have all of their immunotherapy patients receiving immunotherapy in the mornings rather than the afternoon, which is interesting.
So what time did they define it as, Craig? What was the time they used as the cap point?
I think it was 11. I think it was 1 o'clock in the afternoon. The afternoon patients started after 1 and the morning patients were before that.
So the Chinese study, it's 3
p.m.
3 o'clock, which is actually quite late because once you start hanging that means the nurses aren't leaving until 6 or 7. So I think there's the potential for a lot of confounds in that. The other thing I'd like to see is analysis by biological sex. There is a significant difference in the circadian rhythms between women and men. We already know that when you look at many immunotherapy studies that the outcomes are different by sex. So if you throw in something that says biological as our circadian rhythms and ignore the fact that women are not just men without penises, you knew I had to get a genital in there at some point, I think we could end up throwing the baby out with the bathwater and disadvantaging a group of people. I could be completely wrong. But
there was a multivariate analysis, and I presume gender, not sex, was one of the variants. That could be today's quote, was it? Women are not just men without a penis, or it's the other way, men are just women with a penis.
Yeah, that's been, I think. Yeah.
Yeah, look, when I first saw the data around time of day as well, coming from a rural and remote centre, the patients who have their chemo in the afternoons or the treatment in the afternoons are different. Because the people from coming out of town, they're further distances, you might need to see them the same day. You're a bit worried about their wellness to proceed with therapy. For example, so you see them in the morning clinic rather than seeing them a week before and scheduling them, So there's inherent reasons why some people in the afternoon as opposed to in the morning as well. So I don't necessarily think you should always just take it at face value. So I think that's why randomised trials are again to be celebrated because they are testing that. So of course there's a biological plausibility argument for why it would be different, but biological plausibility is not sufficient to make you change your minds about. We just have to be very cautious about the confounders there.
I was surprised to hear that people had already switched practice holus bolus across tumour types. But, this is a low-cost intervention, and maybe if there's further data proving this approach, then maybe we do need a redesign of how we deliver systemic treatments, and with a focus on delivering the immunotherapy component in the mornings. I think we may well need to do that, but I think we do need a bit more evidence before we just have a blanket change in practice.
100%. And then there's the AGIG circadian study coming up, which is a time of day study as well, which I think will be important.
Were you asleep when I was talking about that before and asked you? Did you know?
The colorectal melanoma. I gave you the name. I gave you the name. It was circadian. Did you say the
my
name
question
circadian?
is it in all GI cancers, Chris, I think it's just colorectal, isn't it?
I think it's all DMMR. Yeah, I think it's all DMMR GI cancers, isn't it?
I think that is right, Kate.
Yeah.
We'll just point out we've got a couple of new features, including on our website a tools page. So that topograph database of matched biomarkers and treatments would be an appropriate tool that we list on the tool page. So as we mentioned, various things like the ESMO relative benefit scale, things like that we mentioned in the podcast, we'll list on that page so people can find those resources. And we're also featuring our voice notes. So, technology's lost to me. Rachel's going to explain what to do. Rachel, tell us about these voice note things.
Okay, so go to the show notes and you will see a WhatsApp icon. You click on that and it will open WhatsApp. So if you're doing it on your phone and you've got the app, it will open it in the app. It will also open it in the browser if you're on the computer. And then you can hold down the green button and send us a voice note. And then we can include your comment or question or indeed paper recommendation in the next episode.
Fantastic. And so, you can tell us what a lot of rubbish that interpretation of that paper was, or well done, guys, or whatever you want to do.
That's excellent. And I've just got here the circadian concept synopsis. A randomized phase 2 trial of monitoring morning visits after the administration of immune checkpoint inhibitors in DMMR, MSO high, unresectable or metastatic. No, I'm not frozen. That was just for dramatic effect. Gastrointestinal cancers.
Right. Thank you, Chris. We got there in the end. So thanks very much. I've been getting some nice feedback from people I've run into. And I just want a big shout out to Victoria, who is a breast cancer nurse who is helping to look after my wife at the moment. Thanks, Victoria, for all you're doing. And thanks for your feedback on the show. Thank you, Kate, Chris, and Rachel for today's episode. And we'll see you all in a few weeks.
Matewa.
Kia ora and goodbye.
Always a pleasure. Thanks, Craig. That's it for this episode of the Oncology Journal Club podcast, where oncology papers meet real-world practice. If you'd like to explore the papers we discussed today, head to oncologynetwork.com.au and visit the Oncology Journal Club tab, where you'll find show notes, links to the research, and a growing collection of OJC resources. Don't forget to join the Oncology Network. It's free. You can send us voice notes and chat with us on social media. And physicians, you can also claim CME points for listening to this show. This podcast was proudly produced by the Oncology Network. Until next time, thanks for listening.